Thank you very much. And I commend you all for staying till 4 o'clock on a Friday afternoon with all those other temptations out there. The topics today, really, you've heard a lot about the threats and some of the effects of these threats. What I'd like to talk about very generally is what do we mean by preparedness and what can we do before these threats occur. So this is just an outline of the lecture. You have it in your of the talk. You have it in your handout. And you know, we all respond to emergencies all the time, whether we recognize it or not. You know, there are small emergencies that occur all the time in our daily lives, and to which we personally, and for that matter, the agencies we work for, respond. This was a tanker fire accident at Staten Island a couple of years ago. And then there are larger emergencies. Many people in the hospitals here will recognize the heat emergency. We had blackouts up here and have lost power. And of course that constitutes an emergency for a lot of people, elderly people who could be greatly affected by the heat. Hospitals that obviously, if the power goes out, now have a lot of problems maintaining their services. And of course, then there are the sorts of large emergencies we're talking about. And these, of course, tend to get an inordinate share of attention because of their dramatic effects. The bottom line, and I think, you know, those of you who need to leave early, I can give you the bottom line right now, is that really every agency has to have an emergency response plan, and we happen to be advocates of using the all hazards approach, as Dr. Hall already alluded to. This is actually the way FEMA, the Federal Emergency Management Agency, liked to approach it. That was before Brownie, I'll add. So. And the notion being that there are many things that emergencies of all types have in common, and so you can build a general framework to handle emergencies organizationally and structurally, and then add the special things you need to know, such as the special training you're getting today to deal with radiation threats. Using this approach, we're actually building the pandemic flu plan for the university into the all hazards emergency response model. So this gives you certain advantages, and that you can respond to a wide variety of emergencies in much the same way. Well, what are the special characteristics we might see with, say, an RDD, radiologic dispersion device, or dirty bomb, that you've heard about earlier? Of course, it's an explosive device, so there'll be trauma. And that's familiar to people who work in hospitals and see things like bad automobile accidents or even small explosions. Obviously, there'll be a lot of trauma from the explosive device for those who are in the area. So you can expect, of the explosion, so you can expect a lot of casualties of that type, bomb casualties, basically. It's complicated, of course, by the radioactive contamination, which requires special handling and special care for those who are responding to the emergency. And that's a particular area of expertise you've been learning about today, and that this center has particular expertise in. But there are also, as you just heard, a lot of social effects. Not only will the radioactivity spread in a plume, but probably much further than the actual physical effects. You can expect, obviously, people will be fearful. They will be afraid, obviously, to go anywhere near the area. We saw this with Chernobyl and many other events. And of course, in the area itself, they're covered by the plume. Normal activities will be really disrupted for extended periods of time. And of course, first responders who will go in there and behave, as we just heard from a number of examples, with great bravery and selflessness and heroism, will at some point begin to become concerned about long-term health issues, which was covered earlier today. And then, of course, we have surprises. Think of the effect. What did you think of when you heard of the Litvinenko case? One of the things I thought of was I never knew polonium, that someone could use polonium in this way, although in theory it was perfectly possible. We were all concentrating on explosive devices or dispersion by attacking some kind of nuclear facility, not doing it the other way around and simply internalizing it. And I'm old enough to remember something called the static master brush, which you used to use to clean the dust off your records. And that used polonium, in fact, small quantities, to neutralize the static electric charges. And so, this gives all sorts of interesting associations. You mean that static master brush I took for granted? The same material delivered differently, of course, because it has to be taken internally to be able to do this, which we took very much for granted, obviously is capable of causing death. And so the psychological effects, look at that picture of Litvinenko and what he looked like. We all have seen this famous picture, probably. If not, you're seeing it today, right? It's been publicized many times. That has a tremendous psychological impact. So what do we do in terms of being prepared? The answer, I think, is to be prepared for all sorts of emergencies, including this one. And there's some basic rules that many of you probably already know. If you want to skip early, this is before the sun sets, this is an opportunity. The emergency plan is something every organization should have. As a member of an organization, a healthcare provider, whatever it is you do, you should understand your role in that emergency plan. What are you expected to do in event of an emergency? What is your actual role and responsibility? Everyone should also know, in the plan, it should say, how are you going to be contacted? Will it be by a telephone tree? Will it be by email if you have a BlackBerry? Will they try all of the above? And you should have an idea, when you are contacted, where do you go? And I'm going to give you some examples in a moment of why these are important points. And of course, who are you responsible for? Whom will you be supervising? And who will be over you, supervising you? Because otherwise what tends to happen is we all hear about an emergency and we want to do the right thing. We want to go in there and use our skills. And that's sometimes called freelancing. And sometimes it can be very useful and necessary, but it has certain disadvantages. Consider 9/11, for example, just as a familiar one by now, I'm sure, to everybody here. When volunteers came from all over the city, from physicians and other volunteers with especially medical skills, came from all over the city. And of course, the health department and the city officials were busy responding to an emergency event and did not have the time to use these people simply because they were busy with other things, and many of them probably had skills that would have been important in other circumstances, but unfortunately there were more people who disappeared, we're now finding their remains, than trauma victims, for example. So there wasn't such a great need for trauma surgeons as opposed to other types of expertise. There was no systematic chain of command, so many people were doing their thing, sometimes usefully and sometimes with ill effect. And of course we find what happens to people who respond to an emergency is that very often we want to do everything we can, so we become exhausted. And I saw this in several of my own colleagues, who simply were going for days without sleep. And in fact, one of the harder things to do is to get a second shift of people to come in to replace them. And this is a very important part of the emergency preparations. And then there was that sense of urgency, or maybe it was just inconvenience, that we're now hearing about in terms of responders who did not use their physical protective equipment, like masks, and we're now worried about their health status. A number of years later, they're showing up with various respiratory diseases that might have been prevented by effective use of physical protective equipment. But for one reason or another, it was not used as it should have been. So you do need to have a plan, but it's not enough that takes these factors into consideration. But it's not enough to have a plan. You know, everybody ought to have a plan, but plans tend to go up on shelves and gather dust. And the more elaborate they are, the more dust they gather, except for those that we keep electronically, which, you know, end up getting thrown out or erased with the last hard disk crash. So we should practice and revise our plans organizationally on a regular basis. This is sort of giving you the bird's eye view, if you will. And there are a number of ways you can actually do this. There are actual emergencies with actual emergency responses, like those smaller emergencies I talked about, power outages, for example, that provide good opportunities to test out one's plan and one's capacity to respond. For example, during the blackout a couple of years ago, which covered much of this area, the New York City Health Department discovered that half of their telephones worked. Incidentally, they were the old-fashioned kind, whereas most telephones now are highly advanced, they're digital, and they require power. So they don't work in electrical power outages, something that nobody had realized or at least hadn't thought about. And now the city has gone around and actually inventoried their old-fashioned phones to make sure there are a few available for an electrical emergency. So these are some of the lessons you can learn from doing the real thing. But of course, we don't want to wait for a disaster or an emergency, even a small one, to be able to do this. So you can do various sorts of drills and exercises, starting with what we call the tabletop exercise, a bunch of people sitting around doing essentially a role-playing game with a scenario. How would you react in this situation? A dirty bomb goes off in Times Square. Well, I'm the police department. I would cordon off the area, you know, and so on and so forth. And these often are very useful for building relationships and also finding holes in the plan when we discover that something that needs to be done has not been accounted for, and we don't know how to reach the people who need to do it. And this comes up very often in tabletops. And communications almost always turns out to be the #1 issue at every level in all of these drills and exercises. You can also then take the next step after that and drill parts of the agency or organization, a part at a time. You can do things such as testing the phone tree for the entire organization, or testing the emergency response plan for one portion of it. The advantage of doing that is it's actually very expensive to do a full-scale drill. Those of you who have had to pay for it know that. And that obviously is the next step up, doing an actual drill and seeing how people actually respond to a simulated emergency. And you learn a lot from this. There was one a few years ago, I hope I'm not telling tales out of school, that involved a simulated chemical release from a ship in Brooklyn. And the end result of this, although it was not the intended result of this drill, was that the police and the fire department, which always have their little issues in New York City for some reason, were actually more involved in fighting each other than in responding to the incident, and quite a few members of the fire department got arrested by their police colleagues. We don't think this will happen again, but it was good to know that beforehand. Now I think people will have a clear understanding of their roles, but surprising things come out. And the difference between the US and Israel, which I find quite fascinating, since Boaz Tadmor, the head of the Israeli Home Front Command, was actually a visiting faculty member in my center, a couple of years ago, we discovered that in Israel, they're not afraid to do these things and let it all hang out, although it usually stops short of fisticuffs. Whereas in America, we tend to want perfection, so we keep doing it until we are ready for a drill, meaning we feel we're polished. And often you learn a lot more from just doing it and finding the ragged edges rather than waiting until you're perfect. So don't let the perfect be the enemy of the good, as they say in an English proverb for my British colleagues, and a very good one it is. And you can also work with the community and with other agencies to build partnerships and help share a common point of view, because it turns out that healthcare, public health, and the uniformed emergency response agencies tend to have very different views of the world and operate in a different way. I'll come back to that in a moment. So there are a lot of communication issues. It's like, parents trying to talk to their teenage children or vice versa, whatever, there are cultural differences that you don't notice until you try to work with all of these partners whom you'll need. Of course, it's obvious what you do after you have such a thing or an event. You try to find what went well. A lot of things will. People do improvise remarkably well and rise to the occasion, and find the things that did not go too well. The police and the fire department didn't get along, whatever. And develop, obviously, a plan to improve those things that did not go well. Redo your emergency plan to take that into account. And then, obviously, go back and exercise those weak spots. So this is all pretty obvious, but a lot of this is really pretty obvious. I'm just trying to give it to you in a systematic way. So what's the difference culturally? For example, if you're in public health or many of the healthcare operations, between the way we do things on a day-to-day basis and the way people do emergency response, which will be more familiar to emergency responders. Well, for one thing, in public health, I know, and certainly in academe and in many medical services outside of the emergency departments, we tend to like to do things in a controlled, deliberative, and methodical way. We've been trained to think things through. We've been trained to reach a consensus. In public health, very often, you really try to bring everybody along with you in the entire organization. So it can sometimes take quite a while. And of course, as with any good science, decisions are going to be data-driven. And in many cases, you can wait for the test to come in or for more information to become available. Well, obviously, in serious emergencies, you don't have that option much of the time. You're going to have time-sensitive responses. People are going to have to know what they should do and understand very clearly whom they have to talk to. So it's going to be driven more by chain of command, which is more like a uniform services model. And you're going to make the best decision you can with available information, knowing that it's imperfect. And as more information becomes available, you'll be able to make additional decisions. But things will have to be done sometimes outside our comfort zones if we want to save lives and have a time-sensitive event. If we talk about healthcare organizations, you might be interested to know, if you're in a healthcare organization, who sets those standards? And the answer is, in most cases, many of these standards for what I've been talking about are set by JCAHO, which is voluntary, but almost every hospital wants to be accredited by this organization. And so that has a tremendous effect. And in the last few years, JCAHO itself has been putting in more requirements for emergency preparedness. There's actually an interesting paradox there. I'll just give you a little aside. I asked some people in hospitals, including our own, do you want JCAHO to tell you what you have to do with emergency preparedness? You want more regulation or less? And they said, we want JCAHO to tell us. And I said, why? And they said, you know those managed care organizations? If we do a drill, they'll say, where did you get the money to do that? And obviously figure we have more money than we need, so they'll take some of our money away and start cutting back. As you know, it's a good money-saving gesture. If JCAHO tells us we have to do it, or the government tells us we have to do it, then no one can ask, you know, why we're doing it and think that we're wasting our money. So actually they wanted these regulations as having a way of being able to justify what they knew needed to be done. But unfortunately, sometimes the bean counters, who are important, you know, but sometimes don't understand the context, needed obviously to be kept, to be given a good reason. Then there are a lot of other legal requirements. Those of you who work in hospitals and emergency departments will recognize this alphabet soup, which sets certain standards of care and makes it difficult sometimes to send people to other hospitals once they've walked in your door, even during an emergency. If it's a really big emergency, there's talk about the federal government maybe modifying or suspending this, but that's never happened. And then laboratories have their own regulatory agencies, and we have, you know, other additional requirements that may come from our own state or local agencies. The New York State Health Department, of course, has statutory authority over the healthcare organizations in the state. And then the New York City people, the Bureau of Radiological Protection, for example, you know, has their standards too. So we all have high standards. These are JCAHOs, and they're expanding. JCAHO requires that the organization have an emergency management plan that includes a number of elements, including using the all hazards approach I've told you about, and in a few moments I'll tell you about how you implement this, and cooperative planning among healthcare organizations, which is sometimes not easy to achieve for reasons most of you will probably know, and it's because, you know, we're all in friendly competition. There are additional standards for having regular drills to test emergency management, and involving, in many cases, involving the community, which is a very important concept. Our Israeli colleague, when we talked about bioterrorism, and it's no different with anything else, they live under constant alert, asked me, who is the first responder in a bioterrorism event? And I gave the usual, you know, answer, oh, well, the Department of Health, the local healthcare providers and emergency departments, EMS. And he looked at me and he said, no, the first responders and your first line of defense is the community. So they really have to be involved in this and kept well informed. And that's an art we don't have very well. The jargon for it is risk communication, how to notify the community so that you don't raise their fears unduly without giving them false reassurance. And we've seen many examples of both extremes. We're still learning how to do this well, which is actually interesting, but a very important, often neglected piece. For those people who are in private practice and may not be part of a hospital or something else where it might be a simple decision just to close up for a while, but you have responsibilities. So, you know, you'll want to have a plan for your practice which includes many of the same elements. Communicating with staff, how do they find out whether they need to come in, and you may need people to come in waves as well, and communicating with patients, giving them alternatives if you have to close the office, or you know, letting those who depend on you on a regular basis know that you're available. As a healthcare provider of some sort, if you are, you will probably have a number of decisions to make about your own emergency response role. There are opportunities to volunteer or become part of the emergency response of a hospital or some other facility. And in fact, if you are affiliated with a hospital, they may very well have you on the roster, whether you know it or not. There are also roles with health departments. We have something called the Medical Reserve Corps, both in New York City, and it's not restricted just to clinicians, both in New York City and throughout the country. And I have to tell you, the history is that the Medical Reserve Corps started with an emergency department doc named Richard Hatchett, who was then at Sloan Kettering. He's now at Washington, in fact, who was then the emergency ED doc at Sloan Kettering, who assembled a group of people, including some students from our institution here, to go down to the area right near Ground Zero on 9/11 and offer up their medical services. And they discovered that they stood around for most of a day without having any role, and they were frustrated because they thought they could do something really useful with their specialized skills, but there was no way to employ them. And they also saw people coming in from all over the country who didn't even know where the subway was, which was not operating anyway, maybe it was just as well, who didn't know the area, whereas these people had a great deal of local knowledge. They knew how to find things, how to get things done. So he had the idea of starting up local medical reserve corps that could function in emergencies, especially during the period before there's a big federal response, and actually, have pre-designated roles working with agencies so that they could not only do something, but because in many cases they knew the facilities, they could actually do it very comfortably. So there are a number of decisions about volunteerism. Will you volunteer? And if so, in what organized way can you do it? Okay, having given you sort of all these generalizations, I'll now get very specific and talk about how an emergency plan is actually put into operation. And this uses a bit of a system, which is a bit of jargon for most people in healthcare, called the Incident Command System, or ICS. And ICS is simply a sort of command and control, if you want, a sort of centralized military-like structure which clearly defines the goals and the roles and responsibilities, and then you find what individuals can be made available to fill those roles and responsibilities. So it doesn't depend on any one individual. It's someone filling a role, and you need to have alternates, because any of us could be on vacation or out of town or even get sick, and you don't want, obviously, to have people working 96 hours without sleep. You don't want people feeling that they're indispensable and can't stop. And this is one way to do it that's been devised and is our national standard for doing it in a coordinated way. It was actually originally developed in response to wildfires in Southern California, where they had a lot of different agencies that would come in for a major disaster, and they developed a system for coordinating these activities. So what you have is a defined management structure, I'll show you that in a moment, with defined responsibilities, clear reporting channels, basically a chain of command, although I hate to use that term because it's so unfamiliar to many of us, and a common language, which is often the hardest part. Remember what I said about communications. So just if the basic concepts underlying this is that the chain of command is predictable. You know who, as one of my colleagues, Christine Gebbe, for whom some of these slides were developed as part of a collaborative group that we had at the Center for Public Health Preparedness. As she likes to say, I need to know whom I can yell at and who can yell at me. Who has to obey my instructions and whose instructions do I need to obey? And it should really only be a very small number, one above you ideally, and several people under you. It should be modular and flexible so that you can respond to the emergency as it increases and decreases, sort of like a bellows going in and out. Obviously, accountability and clearly defined roles so that things actually get followed up on and you know what your role is in doing that. And one of those aspects of it is having something which I'll discuss in a moment called incident action plans. These are just plans to explain what needs to be done during a given period of time. The other thing, sort of general concepts with the incident command system, some of you will already know this, and so it'll be redundant for people in uniformed and emergency response agencies, but it's quite alien to many of the rest of us until we've been exposed to it. So there are various types of unified command, but the basic idea is that all the many agencies that are going to be involved in the various aspects of dealing with an emergency have a common and shared set of incident objectives. So they know what they're supposed to do and what the other agencies are supposed to do. You have communications, hopefully, at all levels working well, and this is supposed to facilitate that by limiting the number of places you need to report and communicate with, and centralizing that, and being able to know what resources are available and deploy them effectively. So as a member of this system, in any good emergency plan using ICS, each individual, you report to one other person above you. Below you, if you're not in the bottom rung of the ladder, say you're a department director or unit head, you will have a manageable number, because you have to do a lot of things yourself, but you have to have people you can hand on some of those orders to so they can get it done. Usually it's about 5 to 7 is considered the ideal number, although some parents may disagree with that. This is the generic organization. It's in a sort of a tree structure, like a good organizational diagram, so you're probably all familiar with that concept. At the top is someone called the incident commander. That's the one necessary function. You can actually have a whole ICS with just the incident commander who is running around and then brings in other people and other functions as the job expands. But this is essential, and it's not necessarily your CEO. In fact, CEOs they're good at many other things, but they tend to make terrible incident commanders. If you're in a hospital, it'll probably be some very experienced administrative type nurse. You know, someone who people are not all afraid of, but afraid enough that they'll listen. Underneath, you'll have some, that's why CEOs aren't good. And you can't get CEOs to go home, right? And the whole idea is even the incident commander has to go home and be replaced by somebody else to carry on the job, or you just wear people out. There are other functions for things like safety, liaison with other agencies, and public information. And then you have basically 4 major units, which are called planning. I hope it comes out all right. It's better on this on my screen. The blue here is the chief of the planning section. Operations, logistics, most of these are self-explanatory, so of course I'll explain them in a minute, and finance and administration. And under them there may be others reporting to them, carrying out specific functions. So you can have as much of this tree as you want or as you need, open up more portions of it lower down as you have more needs evolving, and start closing them when things begin to wind down. The incident commander, as I mentioned, directs that response during emergencies. And if there's some sort of emergency operations or incident command post, your incident commander will probably be in there. The New York City Office of Emergency Management actually has a big room like this filled with desks and telephones and computer screens, and I'll remind you they're no longer number 7 World Trade Center, which is where they were on 9/11. Thank goodness they got out before the building fell down. But they've learned from that experience. But they have a big room like this, which is called the Emergency Operations Center. Representatives from a number of different agencies, including our hospital system and many others. And basically the job there is to coordinate all those activities throughout the city with all these different agencies. And the same thing will be happening, at your own institution at a more local level with an incident commander directing it locally. I won't talk about these other staff functions, but you can guess what a public information officer does. And actually that's a very important function because somebody has to be able to answer those tough questions and give out information. We're often reluctant to give out information, and people shouldn't freelance that unless they have been designated to do it. It avoids conflicting messages. Hopefully, public information officers have given thought to what they'll say and how to say it so that the public will be well informed. And we really, I should emphasize, it's something we really should be doing early on, preferably even beforehand with simple messages and then more specific messages as when emergencies do happen. So you're getting that part of the preparation right now throughout this day. The planning section does exactly that. They sort of sit in offices or maybe look out the window, and they get information coming in from various sources, including the other sections and of the organization, and they figure out what is it that needs to be done over the next, say, 24 hours. So they essentially help the incident commander to develop and farm out the incident action plan, the portions of it that are going to be carried out. And of course, the planning section also provides information to the incident commander and the others so that they're not out of the loop. Because otherwise, it could all just be, people running around doing what they think is right. The operations section, these are the doers, the people who like to go out and do things. The athletic types, should be in operations. So in a hospital, this will include a lot of different things, including things like epidemiology, various radiation and environmental monitoring, and a lot of other functions that essentially will try to do many of the specialized things that need to be done and figure out who should do the other parts of the incident action plan to carry it into action. So basically, this is the link between, if you will, the people making up the plans and the ones going out there, which includes many members of the operations section carrying out specific functions. Logistics does exactly that. If you need something Xeroxed, the incident commander shouldn't do it. You should have people to do that. If you need a car, that should be provided for by the logistic section. And security, things like that, the sort of nuts and bolts that are always essential, but we never remember where they are. Which desk drawer did we hide them in? Then finance and administration, all I'll say about that is we often overlook this, but it's amazing how people feel when they've put in all that overtime and discover they're not going to get paid for it. This actually happened in some emergencies, and we learned the hard way, therefore, that whether we want to have finance and administration, they've got to be there to be able to pay things that need to be for things that need to be bought and figure out how to reimburse people for their effort. I mentioned the incident action plan. That's really just the piece of paper that sort of explains what people at various levels are going to do. What are the objectives and what are the things you need to do to carry it out? And there are different units shown here under the various sections that will do this, making concrete the various plans. we talk about emergency response functional roles, and not just a bit of jargon. It really means what you do during the emergency. What is it you're supposed to do? And the chain of command may change during an emergency, or it may stay the same. You know, you may be doing what you usually do, or you may be doing something else under different supervision. And that's obviously what a functional role specifically defines. Many systems, not the official, it's allowed, hospital emergency incident command developed the idea of job action sheets, which I personally think is a very good idea. And basically all this is your job description, what you need to do now, later in the day, and perhaps you know, just before you leave, and hand the task over to your replacement. And this is useful because sometimes, you know, you may not know what a particular function, you know, may mean one thing to you and something else to me. So I think these are handy. We actually have them up on the National Center for Disaster Preparedness website. You can look under resources, and there's a whole animated ICS tree with some sample job action sheets that you can click on that are hyperlinked. And basically that's all it is. What's your job? I'm the incident commander. Who do I report to? What's my mission? And what am I supposed to do? And that's uniform for everyone filling that role, and there's one for each role. As I mentioned, communication is essential. So if you have teenage kids and you know how to communicate with them, you've probably passed the first test. But we find that communications at various levels turn out to be the most common difficulty because people misunderstand or they forget to tell you. And within a given institution, the ICS system helps you by setting up a chain of communications through the chain of command, up, and then communications and requests, and I'll put it politely, requests back. Communicating with the media, I've already mentioned, very important job, should be left to people who are designated to do it, to avoid conflicting messages, and prepared to do it. You'll also be communicating with a lot of friends you didn't know you had. If it's a terrorist event, suddenly Department of Homeland Security, the CDC, of course, you know about them, the FBI, EPA probably, the Federal Department of Energy, they have some response teams, and a whole bunch of other people may suddenly be descending on you, and you will have to learn to talk to each other. So this is why it's helpful to learn these things in advance. There's actually a national sort of umbrella for this, which simply doesn't negate or change in any major way anything I've said. It just adds some other pieces to it nationwide so that everything is consistent nationwide. For those of you who are not in public health, I'll say about 3 words in the remaining few minutes I have. We know what public health does. For those of you who aren't in public health, it's what's done by places like the New York City Health Department or similar agencies. If you are running a restaurant, you probably view them as a supreme nuisance. But they actually do a number of good things as well. One of the reasons we don't have more restaurant food outbreaks and why it's safe to eat in the restaurant most of the time is because of the health department's efforts. And of course, you know, all the various functions normally to prevent epidemics and the spread of disease, protect against environmental hazards, injuries, encouraging healthy behaviors, as we all know by Tom Frieden, our health commissioner's recent examples with smoking and fats, assuring the quality and availability of health services. In New York, that falls to the New York State Health Department, but the city does some of that too, just as a backup. And of course, responding to disasters as one of the responders and assisting communities. In an emergency response, it'll be somewhat different. Many of those functions will go on, like environmental and infectious disease surveillance. but there'll be a lot of collaboration, even more with other and new agencies, and obviously more effort on some operational functions like epidemiology, investigation, environmental health, and public information, and information to medical healthcare providers. As well as possibly, if it's something that needs to be done on a mass scale, the health department, like giving some medication or immunizations, not usually applicable here, but if there were a need for a mass distribution of potassium iodide or something else, chelating agents, public health would be prepared to do that. And so they actually have two jobs to do during the emergency, which is actually kind of tough, but it's just like a hospital. They have to maintain the essential services so that, you know, people don't all get sick and die of foodborne diseases while responding to these additional needs created by the emergency. Not unlike the hospital, because, you know, myocardial infarctions, you know, heart attacks, that is, and other types of emergencies are going to go on all the time. Car crashes will go on the way they normally do. They're not going to stop just because we have an emergency. So these functions help, these systems help in interagency coordination. At the federal level, we've always asked who's in charge. At the city level, the police department has the gun. So, but at the federal level, you know, and they've got strong. But the fire department has stronger fists. We discovered. However, you know, that's a city issue to be resolved within the city government. The federal government has been working on this for quite some time. With new legislation, first the Department of Homeland Security got a lot of the responsibility for coordinating at the federal level, as well as carrying out certain tasks, and bringing in other agencies as well. A recent act passed just at the tail end of the last Congress, just before Christmas, called the Pandemic and All Hazards Preparedness Act, to all of us, of course, known fondly as PAPA, the PAPA bill, actually designates the Department of Health and Human Services as the federal lead for medical emergencies. So for the types of things we're talking about, there will be roles for other agencies, but it's probably going to be the Department of Health and Human Services that will take the lead in doing that and bringing it in, working with DHS, Department of Energy, and you know, a gazillion other federal agencies. But at least that provides a clearer pathway for communication. And there are federal assets available for mass distribution. For example, during the anthrax, during 9/11, and throughout the anthrax attacks, this package from the national stockpile, there are, this is 2/3 of it. It takes up a lot of space. We have 12 such packages throughout the country. They have a variety of things available if you need it. The city and others have plans for being able to give out drugs or immunizations on a large scale using 200 sites throughout the city, largely in public buildings. And the Medical Reserve Corps will be part of the essential personnel because it takes a lot of people to do this. This gives you an idea of how one of these places would operate. A slide from my colleague Nathaniel Eupert at the other place, Weill Medical College of Cornell University, part of our NYPH family. So it's clearly a complex operation that requires something like an ICS. Now, my last word, having gone through all this very quickly, but you know, you can review if you want. I won't give a quiz. I'm told that we won't give a quiz, right? But the last point I want to make is the following. Don't forget to take care of yourself. If you are responding to an emergency, or even in a place where there is an emergency, you are a valuable asset. So you need to protect yourself. And of course, we discovered in talking, giving this kind of, well, more specific training to 800 nurses in the New York City Health Department who work in the schools that their main barrier to coming to work, they wanted desperately to be able to respond to an emergency, but they'd worry about their families, their pets, their parents, anyone else they might have responsibility for. And we saw that in Katrina. So it turns out that you can download one of the better things FEMA did, and the Red Cross has a similar website that's equally good. You can download a personal family emergency plan that simply allows you to plan for these things so that you don't have to worry who's going to take care of the dog or where the kids will be. This will not only give you peace of mind, but hopefully help protect yourself. So you should know how to protect yourself and your family and be assured that there's a plan for them. So this is your own practice at filling out an emergency plan for yourselves. And with that, I simply want to thank you for your time and attention late on a Friday afternoon. Thank you.